Okay, take a deep breath. Just look at this table. We have a literal mountain of paper here. I'm seeing Miller's Anesthesia, O's Intensive Care Manual, Morgan and McKyle, the Oxford Handbook. It's intimidating, to say the least.
It is. And looking at that stack, I'd say we have our work cut out for us, but we aren't just, reading these books today. We're synthesizing them.
Exactly. So I'm stepping into the shoes of the resident, the exhausted, caffeine-fueled exam candidate. And you're my senior faculty. You're the examiner. Our target is the Gujarat University MD anesthesiology exams, but I mean, really, this applies to any high-level anesthesia board exam. We are doing a comprehensive, high-yield revision on the bread and butter of our existence, monitoring in the intensive care unit.
It really is the cornerstone of the specialty. If you can't monitor, you can't manage. But for the exam and for clinical practice, we have to go beyond just, watching the numbers. We need to cover principles, specific types, clinical applications, and crucially, how to avoid failing at the long question, or the Viva station.
Right. So let's set the stage. When I'm sitting across from you in the Viva and you ask me to define ICU monitoring, I shouldn't just say looking at the patient, right? Miller's pretty specific about this.
It is. If you tell an examiner monitoring is just observation, you're already on the back foot. Monitoring is the continuous assessment of physiological function, and its purpose is to guide therapy. It's active, not passive.
Okay, active, not passive. I like that.
You need to emphasize 3 things. Early detection of deterioration, titration of therapy adjusting your noradrenaline or your fluid boluses, and prognostication.
Right. And there's that key phrase I keep seeing in O's Intensive Care Manual. Monitoring itself does not save lives.
That is your opening statement for a long answer. It shows maturity. A pulmonary artery catheter never cured anyone. It's the clinician interpreting the data and making a decision. That's what saves the life. You can have the most expensive Edwards FlowTrack system in the world, but if you don't understand the physiology behind stroke volume variation, it's just a generic late show.
A very expensive nightlight. Okay, so let's break this down systematically the way I'd have to structure it in a theory paper. We usually start with principles.
Yeah.
This is why I often get a bit bogged down in the physics. But the big dichotomy seems to be invasive versus non-invasive.
It is, and the exam question here usually revolves around that risk-benefit ratio. We're always trading patient comfort and safety for data accuracy.
Okay.
Non-invasive is safe, it's easy, and it's usually intermittent. Invasive is continuous and highly accurate, but it carries real risks: infection, thrombosis, pneumothorax. The art of ICU is knowing when the patient is sick enough to justify the risk of that invasive line.
Which leads to the second principle, continuous versus intermittent. I feel like we take this for granted.
We do, but the examiners won't. Think about blood pressure. A non-invasive blood pressure cuff, NIBP, gives you a snapshot, maybe every 5 minutes. In a stable post-op patient, that's fine.
Sure.
But what about the patient on high-dose inotropes or experiencing, rapid hemodynamic shifts?
5 minutes is an eternity.
Exactly. In 5 minutes, a patient can have a major event. An arterial line gives you beat-to-beat analysis. You see the pressure drop instantly. That's the argument for going invasive.
There's another concept that Morgan and McHale stresses heavily: trends versus isolated numbers. I assume this is just the don't treat the number rule.
Precisely. Let me ask you, if I tell you a patient's heart rate is 90, does that worry you?
Not in isolation. It's within normal limit.
But what if I tell you it was 60 an hour ago, then 70, then 80, and now it's 90?
Okay, now I'm sweating. That's a trend. It suggests evolving hypovolemia or pain or maybe early sepsis.
Exactly. An isolated number is a photograph. A trend is a movie. You always look at the movie. And the final principle you have to mention is artifacts. Every monitor lies eventually.
Right.
A damped arterial line underestimates systolic pressure. Diathermy messes up your ECG. Your job is to be the filter.
Clinical correlation is king. If the monitor shows a systole but the patient is asking you for a sandwich, check the leads. Don't start CPR.
Please don't start chest compressions on the talking patient. That would be an automatic fail and probably a lawsuit.
Noted. Okay, let's move to Section 3, basic, non-invasive monitoring. This is the stuff we strap on almost everyone. Let's start with the ECG.
Standard of care, usually we're looking at a 3-lead or a 5-lead setup. For the exam, what are the 2 main things you're hunting for?
Arrhythmia detection and ischemia monitoring, specifically ST segment analysis.
Correct. And lead placement matters. If you're worried about left ventricular ischemia, which lead is your best friend?
V5, usually combined with lead 2 for, P-wave visibility to detect arrhythmias.
Good. Now, blood pressure. NIBP. How does the machine actually know the pressure? It's not listening for cough sounds, is it?
No. It uses oscillometry. It detects oscillations in the cuff pressure that are caused by the arterial pulsation. The point of maximum oscillation corresponds to the mean arterial pressure, the MAP, and then the machine uses an algorithm to calculate the systolic and diastolic from there.
Correct. And that is exactly why it fails in certain situations.
When does the cuff lie to you?
In shock states, definitely, when pulses are weak. Also in severe arrhythmias like atrial fibrillation, the irregular beat just confuses the algorithm, and extreme obesity.
Cuff hypertension. If the cuff is too small for the arm, you get falsely high readings. You've always got to match the cuff size to the arm circumference.
Right.
Now, let's talk about pulse oximetry. This is a favorite short note topic.
It's PO2. It works on the Beer-Lambert law. It uses two wavelengths of light, 660 nanometer, which is red, and 940 millimeter, infrared, to distinguish oxygenated from deoxygenated hemoglobin based on their absorption spectra.
That's the physics, and you need to write that down. But what's the clinical trap?
The lag time. SpO2 drops late. If a patient stops breathing, say from an opioid overdose, their saturations might stay up for a minute or two because of their functional residual capacity, especially if they were pre-oxygenated. It monitors oxygenation, not ventilation. 10 points to Gryffindor. That is the crucial distinction. SpO2 tells you about oxygen in the blood. It does not tell you if the patient is moving air right now. For that, we need something else, which we'll get to.
Okay.
One quick note on temperature. It's often called the neglected vital sign.
Right. We monitor core temperature, esophageal, bladder, or rectal. Peripheral temp is less accurate for the core, but the gradient between the two is diagnostically useful, isn't it?
Huge. A widening gap between core and toe temperature. Where the core is hot but the toes are cold, that's a sign of clamping down. It indicates shock, specifically increased systemic vascular resistance.
I see.
And obviously in anesthesia, we monitor temp to catch malignant hyperthermia early.
Okay, let's step it up. Section 4, advanced invasive monitoring. This is where the long questions usually land. Let's start with cardiovascular, the arterial line.
Invasive arterial blood pressure. The indications are pretty straightforward. Hemodynamic instability, the need for frequent blood gas analysis, or beat-to-beat monitoring.
Radial is the most common site, but we also use femoral, brachial, dorsalis pedis, axillary. For the Viva, I know I'm going to get asked about the Allen's test.
You absolutely will. You'll be asked to demonstrate it. You compress both the radial and ulnar arteries, have the patient clench their fist to blanch the hand, and then you release the ulnar artery. You want to see that flush return in under 5 to 10 seconds.
But honestly, Miller points out that the predictive value of the Allen's test for ischemic complications is, well, it's actually pretty debatable.
It is controversial, but for the exam, you perform it and you document it. It's a standard of care issue.
Got it.
Now look at the waveform itself. It's not just a squiggle. You have the systolic upstroke, the peak systolic pressure, the dicrotic notch. What does the dicrotic notch represent?
Closure of the aortic valve. It marks the end of systole and the beginning of diastole.
Good. And complications?
Ischemia, thrombosis, infection, aneurysm, fistula, and the nightmare scenario, accidental intra-arterial drug injection.
Absolute disaster. That leads to gangrene and amputation. You always label your lines. Now let's talk CVP, central venous pressure. This is a bit of a minefield in modern ICU, isn't it?
Yeah, the sources are pretty conflicted, or maybe the consensus has just shifted.
Yeah.
CVP is the pressure at the SVT-RA junction. Classically, we were taught it assesses preload and we should aim for a CVP of 812.
Right.
But the modern literature, backed by Marino and Miller, suggests that static CVP is a terrible predictor of fluid responsiveness.
Spot on. A low CVP doesn't guarantee a patient will respond to fluids. Their heart might be on the flat part of the Starling curve. And a high CVP doesn't always mean they're full. They could have right ventricular failure or tamponade.
Okay.
However, don't throw it out completely. It is useful for assessing right heart function and as a safety limit. If the CVP is 20 millimillichi, you probably shouldn't be pushing fluids blindly.
So it's a stop sign, not a go sign.
I like that, yes. Now, moving to respiratory monitoring, we mentioned SpO2 has a lag. The solution is capnography.
This is high yield. I'm putting a star next to this. Capnography is the continuous measurement of CO2 and exhaled gas.
And its primary absolute gold standard indication.
Confirmation of endotracheal tube placement. If you don't see that square wave, the tube is not in the trachea.
Right.
Or the patient's in cardiac arrest.
No trace, wrong place. It is more reliable than listening to the chest. But beyond placement, look at the waveform. It tells the story. What if you see a shark fin appearance?
And that's bronchospasm, asthma, or COPD. The expiratory upstroke is prolonged and curved because of airway obstruction preventing the fast exit of gas.
Exactly. And if you see a sudden, precipitous drop in end-tidal CO2 to near zero, but the tube is still connected.
Cardiac arrest. No cardiac output means no CO2 is being delivered to the lungs to be exhaled. It's actually a great monitor for CPR quality too, isn't it? If you get the ETT CO2 above 20 millimilli Hg, you're doing good compressions.
Correct. It's a circulation monitor as much as a ventilation monitor. Don't forget, it's also used for dead space calculation Bohr's equation. Keep that in your back pocket for the physiology Viva. Now, neurological monitoring. This scares people.
Be included.
Yeah.
GCS is standard, but invasive ICP monitoring is the hard part.
Indications.
Severe head injury with a GCS of 8 or less and an abnormal CT scan, or a normal CT if they have other bad signs like hypotension or posturing.
And the gold standard method.
An intraventricular catheter, an EVD.
Yeah.
Because you can also drain CSF to treat the pressure, not just monitor it.
Correct. Now, I want you to visualize the waveform. It has 3 peaks, P1, P2, P3.
P1 is the percussion wave. That's the arterial pulsation.
Sure.
P2 is a tidal wave related to brain compliance. And P3 is the dicrotic wave.
Here is the exam tip that separates the pass from the honors. In a normal brain, P1 is the tallest. P1, P2, P3. If the brain is tight, if compliance is reduced, P2 shoots up. If you see P2 higher than P1, that is a dangerous brain.
Oh, okay.
That patient is running out of intracranial space.
That's a great visual. P2 higher than P1 equals danger. The tidal wave is rising.
Exactly. Quickly on sedation, we use scales like RAS, the Richmond Agitation Sedation Scale. But for paralyzed patients, or in general anesthesia, we need processed EEG, like BIS, the bispectral index.
Right. BIS gives a dimensionless number from 0 to 100. For GA, we aim for 40 to 60. It helps prevent awareness and lets us titrate drugs so we don't overdose them, especially in the elderly.
Moving on to renal, it's simple but vital, urine output.
The target is 0.5 to 1 LLK-ZHR.
But be careful, high urine output doesn't always mean good perfusion. Think about high blood sugar causing an osmotic diuresis, or a patient who just got Lasix.
True. Context is everything.
Now, Section 5. This is probably the hottest topic in exams right now, hemodynamic monitoring. We touched on this with CVP, but let's go deeper. The shift from static to dynamic parameters.
Okay, let's unpack this. Static parameters are things like CVP, or pulmonary artery wedge pressure, POWP. They look at pressure at a single moment, and like we said, they're poor predictors.
Correct. So we look at dynamic parameters, pulse pressure variation, PPV, and stroke volume variation, SVV. How do these work?
They rely on heart-lung interactions. So when a patient is on a ventilator, the positive pressure breath sort of squeezes the heart. It increases intrathoracic pressure, which decreases venous return, the preload to the right heart. And then a few beats later, that translates to a drop in left ventricular output. If the patient is empty, if they're fluid responsive, that squeeze causes a significant swing in the blood pressure or stroke volume from beat to beat. If the tank is full, the heart doesn't really care about the squeeze. The variation is minimal.
Exactly. If the variation is high, usually defined as more than, say, 12, 13%, the patient is likely to respond to fluid. If the variation is low, fluid won't help. You need vasopressors or inotropes.
But there are major caveats, right? The patient has to be in sinus rhythm, closed chest, and uncontrolled mechanical ventilation with decent tidal volumes.
Yeah.
Usually at least 8 millipilograms.
Yes, and that is the classic Viva trap. Doctor, can you use SVV in this patient with atrial fibrillation, or can you use PPV in a patient breathing spontaneously on CPAP? The answer is no. The arrhythmia messes up the beat-to-beat calculation, and spontaneous breathing creates unpredictable pressure changes.
So for those patients, we might need something like a passive leg raise test.
Exactly. It's a reversible fluid bolus. You tip the legs up, gravity dumps about 300 milliliters of blood into the heart. If your cardiac output goes up, they need fluid. Simple.
Let's talk about Section 6. Monitoring during mechanical ventilation. The ventilator screen is full of loops and numbers. It can look like the cockpit of a fighter jet.
Focus on pressure and volume. There are 2 key pressures you must distinguish: peak inspiratory pressure, or PIP, and plateau pressure, P-plat.
Okay, so PIP is the highest pressure reached during the breath. And P-plat is the pressure in the alveoli when flow stops, like during an inspiratory hold.
So what's the clinical significance of the gap between them?
This is the diagnostic money shot. PIP reflects resistance and compliance. P-plat reflects only compliance. So if PIP is high, but P-plat is normal, the problem is resistance. The straw is narrow bronchospasm, a kinked tube, or the patient is biting the tube.
And if both are high.
Then the compliance is bad. The balloon is stiff. Think ARDS, pulmonary edema, pneumothorax, severe obesity.
Excellent differentiation. If you can explain that clearly in an exam, you are doing very well. Also, don't forget PEEP positive end expiratory pressure. In patients with COPD or asthma, we have to watch out for auto-PEEP, air trapping.
You can see that on the flow time scaler, right?
Right.
The expiratory flow doesn't return to 0 before the next breath starts.
Precisely. That trapped gas increases intrathoracic pressure and can cause hypotension or even cardiac arrest if it builds up enough.
Section 7. Laboratory and biochemical monitoring. We aren't just looking at bedside machines, we need to look at the blood. And lactate is the big one.
Lactate is a marker of anaerobic metabolism, of tissue hypoperfusion. But is a single lactate value useful?
Not as useful as the trend. We look for lactate clearance. If you resuscitate the patient and the lactate drops by, say, 20% in 2 hours, that's a good sign. If it stays high despite your efforts, mortality skyrockets.
What about SCVO2, central venous oxygen saturation?
This measures the oxygen saturation of the blood returning to the heart, usually from a central line in the SVC. Normal is about 70–75%. It tells us about the balance between oxygen delivery and oxygen consumption.
So if it's low, say 50%.
It means that tissues are extracting way more oxygen than usual because they aren't getting enough.
Yeah.
So either your delivery is low cardiac output, low hemoglobin, hypoxia, or your consumption is high fever, pain, shivering, agitation. It's a global warning light.
Exactly. Section 8 covers sedation, analgesia, and neuromuscular blockade. We mentioned RASS for sedation. What about pain?
Pain is the 5th vital sign. In alert patients, we use the numeric rating scale, 0 to 10. In unconscious patients, we use behavioral scales like the CPOT, the critical care pain observation tool, looking for grimacing, muscle tension, fighting the vent.
And if you've paralyzed the patient with muscle relaxants,
We have to monitor the depth of block to avoid 2 things. Aware paralysis, which is just psychological torture, or prolonged paralysis, which leads to critical illness myopathy. We use a peripheral nerve stimulator, the train of 4, or TOF.
where do you put it?
Usually the ulnar nerve watching, the adductor pollicis muscle, the thumb twitch, or the facial nerve. We're looking for the number of twitches. 0 out of 4 is a deep lock. 4 out of 4 is light.
And why does the site matter?
Because the diaphragm recovers faster than the thumb, but the face recovers even faster than the diaphragm. So if you wonder if the diaphragm is paralyzed for intubation, you monitor the face, or orbicularis oculi. But if you want to know it's safe to extubate, you monitor the thumb. If the thumb works, the diaphragm definitely works.
Brilliant nuance. That's a senior resident answer. Also, don't forget delirium. It's huge in the ICU. We monitor it using the CAM ICU tool. Confusion assessment method. Delirium increases mortality, so we need to screen for it daily.
Section 9. Complications, errors, and artifacts. We touched on this, but let's formalize it.
Invasive lines are dangerous. Pneumothorax during CVP insertion is a classic. That's why we use ultrasound guidance now. It's the standard of care to reduce complications. An infection CLAB-SI, central line-associated bloodstream infection, is a major quality indicator. If your unit has high CLAB-SI rates, you have a problem.
And regarding data interpretation, let's go back to damping in arterial lines.
You can have overdamping or underdamping.
Right. Overdamping, like if there's a clot, a kink, or an air bubble in the tubing, it makes the waveform look all smoothed out. It underestimates your systolic and overestimates your diastolic. The MAP usually stays accurate, though.
Correct. And underdamping or rinning makes the waveform look spiky. That happens with excessive tubing length or stopcocks. It drastically overestimates systolic pressure. You check this with the fast flush test or the square wave test.
Section 10. Role of monitoring in clinical decision-making. This is the synthesis. We don't monitor for fun. We monitor to act.
Right. So escalation of care. If the lactate is rising and the SCVO2 is dropping, you don't just document it. You intervene. Fluids, inotropes, maybe intubation.
In weaning, we use monitoring to decide when to take the tube out. We use the RSBI, the Rapid Shallow Breathing Index, respiratory rate divided by tidal volume in liters.
And if that RSBI is less than 105, it predicts a successful extubation. If they're breathing fast and shallow, high rate, low volume, the number goes up and they aren't ready.
And finally, prognostication. We use scores like Apache or SOFA, which rely heavily on these physiological variables, GCS, creatinine, bilirubin, BP, PaO2, to predict mortality risk.
Now, Section 11, common exam questions and Viva traps. We've been sprinkling these throughout, but let's hit the big ones.
Okay, the biggest trap is the normal values trap. An examiner asks, is a BP of 11/10/70 normal?
And the answer is, it depends on the patient. For a healthy 20-year-old, yes. For an 80-year-old with chronic hypertension who lives at 1690, a pressure of 1170 represents relative hypotension. Their brain and kidneys might be hypoperfused at that level.
So normal is relative to the patient's baseline. Okay, another trap. Does a pulse oximeter measure ventilation?
No. It measures oxygenation. Capnography measures ventilation. You need to say that loudly and clearly.
And the CVP trap. Does a low CVP mean I should give fluid?
No. It means the right heart can accept fluid, but not necessarily that the cardiac output will increase. The correct answer involves checking dynamic parameters or doing a fluid challenge.
Perfect safe answer. Examiners love safety. Always mention checking alarms, zeroing the transducer to the phlebostatic axis, and confirming line position with an X-ray.
Section 12. Diagrams and exam presentation. If you get a long question on ICU monitoring, you cannot just write text. You have to draw.
Visuals stick. So what are the must-draws?
You must practice drawing the normal CVP waveform, labeling the AC, V waves, and the XY descents. Draw the arterial waveform with the dicrotic notch. Draw the capnography waveform phases 1, 2, 3, phi, and the ICP waveforms showing P1, P2, P3. A label diagram is worth half the marks in a short note. It shows you understand the morphology, not just the numbers.
That is gold. Section 13, summary and exam conclusion. Let's wrap this up with a high-yield recap for the drive to the exam center.
Go for it. What are the takeaways?
Okay. 1, monitoring is not therapeutic, it guides therapy. 2, trends are always better than isolated numbers. 3, clinical correlation is mandatory. Treat the patient, not the monitor. 4, non-invasive is safe but intermittent. Invasive is continuous but carries risk. 5, SpO2 lags. Capnography is real-time ventilation. 6, static CVP is poor for fluid responsiveness. Use dynamic parameters like PPV or SVV if the patient fits the criteria.
Good.
7, lactate clearance is a better prognostic marker than a single lactate level. 8, in ICP monitoring, P2 greater than P1 means dangerous brain swelling. 9, the difference between PIP and P-plat tells you about resistance versus compliance. And 10, safety first check alarms, use sterile technique, and zero your lines.
That is a solid summary. If you can articulate that in your exam, you will pass. My final advice for the conclusion of your answer, always end by saying that monitoring is multimodal. No single monitor gives the whole picture. We integrate CNS, CVS, and respiratory data to build a physiological model of the patient.
And for you listening, try to visualize those waveforms. Close your eyes and see the dicrotic notch, the shark fin capnograph.
One provocative thought to leave you with, drifting a bit into the future. We are currently obsessed with macroscopic variables BP, heart rate, but the future is microscopic. We are moving toward monitoring mitochondrial function, real-time genetic expression in sepsis, and using AI to interpret these massive data streams. The monitor of the future won't just beep, it might tell you what to do.
That is both cool and terrifying. But for now, I'll stick to mastering the arterial line trace. Thanks for the session, Professor.
You're welcome. Go ace that exam.
Thanks for listening to this deep dive. Good luck with your revision.